Well, good afternoon, everybody. I'll talk a little slowly in the beginning here because I know some people are still logging in. But I just want to say this is the third time I've given this webinar, and it's evolving because the first one was how to keep workers during the pandemic. And we've kind of modified it a little bit to also how do you not just keep workers, but how do you get a return to work policy and procedure, and also address how do you bring customers back. This is going to be about a 30-minute discussion here, or I should say presentation. I'm not going to go into too much depth about how to bring customers back and how to focus on the public when it comes to getting them into your work, into your various commercial establishments. I think that could be a secondary thing here. This is going to be mostly dealing with the issue of developing a return to work program and procedure and strategy. A little bit of background about who I am. Emilcott is a consulting, environmental health and safety consulting firm, a little under 50 people. We're here in Florham Park now. We moved from Morristown. We mostly deal with commercial and industrial, pharmaceutical, transportation, healthcare, and providing all sorts of environmental health and safety services. We have now gotten into the COVID-19 business, and it wasn't part of the business plan for 2020, but part of the procedures and exposure assessments and use of personal protective equipment and planning, this is in our core competency. So we're not necessarily dealing with chemicals or other types of hazards. We're now dealing with an infectious disease. So, but the fundamentals are the same. A couple of beginning slides here is there are 3 goals here I put on the slide, and the first 2 goals are pretty much what has been the major overriding goals for trying to protect people in the pandemic. The first one is, and I think everybody's heard about this, flattening the curve. We don't want to overwhelm the healthcare system. We of course want to keep people safe, so that's critical. But the third goal has really been kind of completely pushed aside during the beginning of this pandemic. And now we want to bring it back in, that we do want to keep people working and the economy moving. And the point I'm trying to make is you can do number 1, you can do number 2, and still meet the goal of number 3. A little bit about our friend here, the virus. When you see SARS, which deals with respiratory issues. It's SARS-CoV-2 is the virus itself. And you can see everybody knows COVID-19, coronavirus disease 2019. But I think it's also important to realize these viruses are not a living organism. They are a protein that's about, I have it, 0.1 micron. And that's very difficult for people to kind of grab at what is how small this is. I have a 0.1 millionth of a meter, and I'm not going to talk about anything from a relative stamp side, but that's important when you start looking at respiratory protection and you start looking at this virus that can move around with some degree. I want to start by talking about risk communication. I call it risk communication 101. It's something that we've been involved with. I personally have been involved with this for quite a long time. And the whole aspect of risk communication is, what are you trying to accomplish? Okay, what behaviors do you want to change? And when you start looking at the first message here, we had a crisis, and what was decided either directly as part of the strategy or kind of evolved, is that we really needed to make a radical change in behavior of the public. And everyone saw all the kids that were on spring break down in Florida on the beaches, And that's kind of ratcheted up a little bit more, that we needed to get everybody taking this very seriously. And the messages come from the infectious disease doctors. We all know Anthony Fauci, and he's been on a daily overview of what's going on, epidemiologists, a lot of politicians, our governor, Governor Cuomo, and Governor Trump, and of course the president. And the press has taken the ball and run with it and said this is you know, something that is very important. But when you're dealing with a crisis, there's a couple things that you want to get across. One is that there's a high sense of urgency, that people cannot make independent decisions, and there is no room to interpret the risk. And that's the message that's come down, and that's why people are acting the way they are. What we want to do is transition that message from a crisis into a post-crisis, and that's a major push right now. And you got different people talking right now. Industrial hygienists, for example, that's been my practice, and that deals with understanding relative risk, understanding how to protect people from this risk, trying to rank risk according to what the exposure potential and the severity is going to be. Toxicologists are in the concept of dose, and I'll talk about that in a minute. And then, of course, we got our business leadership. This is one reason we're getting involved with the Morris County Chamber, that the business leadership has to kind of take the dialogue, take the message away from some of the healthcare people that are still making this a crisis, and saying, yes, it's very, very, very much of a concern, but it can be managed. And so when you have a message like this, you want to relax the sense of urgency. You want to start pushing that science can inform people to make independent and different decisions. It's not the carpet bombing approach where everybody's the same, everybody has to shelter in place, that we can come back and actually perform work and work for a normal life with some precautions. And so I think it's important that in this message that we're going to apply what is known as risk management principles in order to make things get back to normal as much as possible. The other thing I think it's important to recognize is that we are dealing with two different types of cohorts. Now, what a cohort is a group, okay? Now, workers are workers, and they typically are age 18 to age 65. They can go a little bit farther. They tend to be, from a health standpoint, healthy people. We can control workers with regards to management systems. So I think we have this work, and I'm going to focus mostly on getting the workers back into the workplace. There's also the public. Public's a little bit more challenging because you want to get customers into your establishments, and you want to get people getting back into the economy, so to speak. You can apply the same risk thresholds to the public. You just have to apply them differently. But for this talk, I'm going to focus on the workers because it's a little bit more fundamental. And once you get the workers in, then we can focus on the public. I'm going to discuss the concept of dose, which is something I live with constantly when you're trying to explain what is a health risk with regards to a relationship between a quantity of something that you're exposed to how bad is that exposure going to be? How deleterious is it going to be? And of course, you start dealing with chemicals and pesticides and physical hazards, radiation. I mean, a lot of people have talked about drugs as another area. So, and kind of the simple explanation is generally okay, and this is a glossy end. A lot, it's not. So you want to make sure that you have an understanding that dose can be applied from a scientific standpoint to trying to understand what the hazards and risks are to whatever chemical, or in this case, infectious disease. And when you deal with viruses, the whole concept of dose actually does apply also. And this is something that has not been, when we go back to the risk communication part, number one, there was no discussion on dose, that a little bit of the virus is not going to be as bad as a major super spreader type exposure. So this is a discussion that has to come back in, because when we start managing and doing risk management, we're going to classify people according to what we think they're going to be exposed to. To just reinforce that infectious diseases can also fall into the dose response curve. This is a paper that OSHA commissioned a number of years ago, trying to determine if it was possible to identify what is known as thresholds of infectious disease, infectious viruses, for example, not infectious disease, but viruses. And the conclusion was they can't get numbers out there, but it's an interesting paper that tries to, again, put science back into the discussion when you're trying to manage a disease like COVID-19. OSHA has gotten in on the bandwagon here, and they put a guidance out with preparing workplaces for COVID-19. And one of the things that they ended up doing, which I think is very, very helpful, is they did put together this, this risk pyramid. And again, this is a dose issue where you start looking at those jobs that are considered very high or high. It's anticipated that the potential for exposure and the quantity of the exposure to the virus would be very high or high. I mean, that's the concept. Then you have jobs that are medium and lower risk. And that's where you say, well, there's a potential for exposure, but we anticipate that the probability of exposure is low, and the actual quantity or mass of exposure would be also low. Their definition, and the point I'm trying to make here, is the majority of the jobs, if you look at the two bottom ones here, high and very high, the majority of the jobs of the employers in Morris County are not going to be high or very high. The exceptions being in the healthcare industry. And basically, when you start looking at who has a very high or who has a high exposure risk, a high risk, those people who are actually attending to sick COVID-19 people, or sick COVID-19 sick people. And of course, if you're intubating a ventilator in a person, you can't get a pathway that's any more severe in trying to come into contact with the virus itself. But I'm going to exclude healthcare for the most time. I'm going to talk about medium and lower jobs. And when you start looking at the medium jobs, basically the definition here is where you may have contact with people. And you could look at a cashier at a grocery store, for example. I mean, they're having plenty of contact with people. But we want to basically say that these people are not people who are infected or known to be infected with COVID-19. And, so you're not dealing with people. Plus, you can actually have contact, but you can keep your distance away from these people. The lower ones are jobs that, frankly, you just don't have that much contact with people outside of maybe your workforce. And, you can keep your distance, you can segregate yourself. And you have minimal contact, you have minimal exposure, and you kind of determine from a risk standpoint, it's a lower risk. I think it's important to talk a little bit about some of the personal protective equipment that's out there, because everybody's doing different things. And it was interesting when you read the OSHA guidance on lower risk and medium risk. One of the things that they say is you really don't need to wear a mask. You really don't need to wear a respirator. That has changed, and we're seeing a lot of procedures that are changing. I don't think it's good or bad at this point. I think it's possibly good practice to wear a mask or wear a respirator, depending on your job. So let me talk a little bit about what a mask is and what some of the science behind it. They really have two different kinds of masks that people have. The surgical masks, the homemade masks, whatever you want to call them, these are not designed to use to filter out any viruses. And I think everyone has heard different things about these masks, but they're basically designed as a barrier for two reasons. One, they want to make sure that you are not creating a pathway if you're talking, if you're sneezing and things like this, that you basically contain it within the mask. And it does prevent you from having your face, or excuse me, having your hand touch your face or touch your mouth and things like this. So it's a barrier. I think it can reduce the potential for exposure. It can keep the risk and the probability low. But it is not necessarily something that is going to eliminate exposures. N95s are something that no one knew anything about N95s except kind of a small group up until about 2 months ago. But these are what they call filtering face piece respirators is what we talk about. And you've seen a lot of them around. And they do, the respirators themselves can filter out the virus itself. And from a health and safety standpoint, it can, from an aerosol, it can filter out the virus. There's a couple exceptions though, is that one, it has to have a tight seal. And when you have a tight seal, it assumes that the person's clean shaven. And I've seen lots and lots of people walking around with N95 masks that have facial hair or beards underneath it. And in that case, it really isn't doing the job. You get tremendous amount of leakage. We actually have what is known as a quantitative fit test, and we can measure the leakage on these masks. And just trust me, it doesn't work very well. It also requires, when you have N95, that people are fit tested to make sure that the mask is actually functioning as the mask should. So that's the basic difference between the two. The N95, as I said, has something called a protection factor, and that basically is trying to model or determine how much do they leak. Because here you have a mask that you're putting on someone's face. Everybody's face is different. They do leak. There's usually, in many of these cases, they don't even have a rubber seal. It's kind of the filter material is actually next to your face. And the way you model this is that you basically are determining that it's about an 80% efficiency. Now, if 80% efficiency, once you are clean shaven and once you have fit testing, and that doesn't seem to be very high. But again, from a risk standpoint, when we're talking about trying to reduce exposure, you're not necessarily eliminating exposure. You are reducing it to as low as you can. And from a dose standpoint, that reduces the hazard and reduces the probability of disease. These other slides here is that the N95 does remove particles from the air, and I have something here about the size of the particles, which you can look at when you have an opportunity. When you're bringing people back to work, one of the things that you want to make sure is, especially if you start using personal protective equipment, there are a lot of laws out there. There are a lot of rules that need to be followed, and OSHA tends to be the driving jurisdiction for a lot of these rules. And that basically you have two different requirements here. If you have a voluntary use of respiratory protection, or if you're using something that's not a respirator, like a mask, you really don't need to have a full-blown respiratory program. However, if you require people to use N95s, these are respirators. These are designed for protecting you from whatever the hazard happens to be, in this case the virus, that does trigger by having an employer mandate that you have to wear respiratory protection. It does trigger the full requirements of the OSHA respiratory standard. And those requirements are that you have to have a written program, you have to have some means of medically qualifying people to wear the respirator, and you have to fit test. So we guide companies to say if you don't want to necessarily trigger the respiratory protection program and everything else, then you may not want to necessarily mandate the use of N95 masks. If you do, you got to do it right. Another interesting occupational health standard issue is record keeping. And this is something that OSHA has come out, and it might not seem to be a big deal until you get involved with it. But the issue is, how do you record an illness of a worker that works for you, and do you record it as a occupational health incident? In other words, if one of your workers comes down with COVID-19, do you have to record that as on your injury and illness record keeping? And does that potentially trigger workers' compensation? And there's the advice we've been giving out, and we base this on some of the guidance document that's out there by OSHA and other places, is that if you have a confirmed case of COVID-19 in the workplace, and it basically, the person is going to have to be either quarantined, or they're going to come out of the workplace, and you hope they're going to be fine. You have to determine if the case is work-related. And our policy basically is that if it's a low or medium job, we classify it as low or medium in the risk criteria that I talked about previously, then you do not declare this as a work-related case. It changes when you have a healthcare situation. If it's a high or very high, it's a lot more difficult to, or I should say it's a lot easier to link the exposure to the disease. But when it comes to low or medium or lower or medium jobs, risk level jobs, we don't consider that to be work-related. Therefore, it would not be a reportable incident. So the action items, if you have a workplace and you're trying to get back into work and you want to make sure you're doing all the right things, the first is take a risk-based approach to classifying employee work functions. We work through this. Look at your work functions, and if you happen to be a dealership of some sort where people are coming in, you can basically say that you can keep some social distance, you can have some screening, you can do whatever it is, that you would have a lower or possibly a medium, if I gave the example of a checkout person at a grocery store. But it's an affirmative thing that you want to make sure that you don't classify people as high or very high, unless indeed they're working with sick people. I say take a three-phased approach. The first phase is to get people back into it. So this is the most severe phase, okay? You're going to possibly require some sort of mask. You're going to have social distancing. You're going to segregate people. You're going to take a very, very aggressive approach to get people comfortable and confident to get back in. The second phase, you're going to lessen those, and hopefully the third phase is going to get a little bit closer to normal, like it was in January and February of this year. But that's an evolution as part of your return to work program. The third is that you want to be prescriptive. Tell people what they're supposed to do. Don't leave it up to assumptions. Changes in work practices, how you're cleaning the facilities, personal hygiene, a lot of the do's and don'ts that everybody's practicing right now. Try to keep your work clothing segregated from taking them home, use of personal protective equipment, reporting symptoms. These are things that are part of your program, And you basically are telling people, depending on their classification of your job, what they're supposed to be doing. Action items on this. You want to put together a COVID-19 health and safety program. I talked a little bit about some of the elements of those in the previous slide. You're also going to have, from a company standpoint, you got new policies you got to put together. What's one of the new policies? Work from home policies. I think people have been working from home. Now you're determining, do you want them to come back? Do you want to work from home? And how does that work within your group and trying to reduce the risk of exposure to the rest of your employees? The importance of reporting and self-quarantining. There's a lot that's being written right now on the ADA requirements, American disability requirements, and can you ask people if they have been exposed? Can you ask people questions from a medical standpoint that's related to COVID-19? And the answer is mostly yes, you can. So the other is self-quarantining. Do you want necessarily people to make independent decisions about self-quarantining? My advice is no. You want to have people report, and then it would be something that is a decision that is made along with your supervisor or along with the company if people need to self-quarantine. And record keeping. Record keeping we just discussed before, but that's important to keep good records with regards to what you're doing and how you're protecting your employees. The third bullet here is getting back to my risk communication 101. And this is very important because people are very concerned about coming back. People are very concerned. When I was, after 9/11, we were very much involved with a lot of the workplaces at American Express building, for example, and trying to get them back into Lower Manhattan. And so we developed a very specific risk communication process to try to communicate the hazard, communicate the risk, get people to talk about what are some of their concerns. You want to talk about why it's a low or medium risk in the workplace. You want to explain that you have these protocols in place that are protective and that you're going to evaluate and make sure people are trained. And so it's important to have this policy of communicating risks to not just your workers, but when you also are looking at your customers, to communicate that you have an aggressive program, a well-managed program that can protect people. And also, since this is a disease that can be where exposures outside of work are often much greater than they would be in work, you want to also communicate that it's important to be vigilant and have best practice when you go home. I do have a couple slides here on cleaning because people are interested here. And understand when you're dealing with this virus, as I said earlier, it's not a living organism. It has a kind of a fat layer, very thin fat layer for a protein molecule that you basically want to melt fat. And that melt fat can be done with any sort of detergents, alcohol, and they say it's greater than 65%. You do have a lot of discussion about how long does this virus hold up in ultraviolet light, in the environment. So the good news is if you have an area that is not being used for a day or two, the probability of having significant amount of the virus is lower. There's, it does drop quite a bit, but that does depend on the surface and the environment that you're in. There's also a list of disinfectants. They call it the EPA List N. You can Google that, and if you want to know what are the approved disinfectants, then the list is there. This is the kind of ABCs of how to disinfect. We talked about wait time. We're looking at involved in disinfecting hotel rooms that are being used by healthcare people. Okay, and a part of our process is to wait 3 days before we clean the room. And it might be overkill a little bit, but at least you waiting 72 hours with the understanding that this virus will not survive. And you have cleaning to remove the soil, disinfection, wiping surfaces, and disinfecting fabrics. So lessons learned. This was a slide dealing with hiring outside cleaning contractors. And like all sorts of crises or so, everybody's trying to get into the business and such. So you have a lot of people kind of getting into this. And if you end up getting people to clean your operation, some of the lessons learned we've learned from the last 6 weeks or so of providing oversight and managing this is that some of the new hires are not from, there's a lot of compliance gaps from a health and safety standpoint, training, lack of training, inadequate PPE, and they tend to be rushing people into this business. So it's not that it wouldn't be difficult to get people up to speed on this, but it's kind of buyer beware. And if you're performing any sort of cleaning, you want to make sure or involved that they're following or hiring people that have some specifications. They have a checklist on how this is actually being done, and there's some sort of defensible reporting at the end. So that's the overview of some of the return to work procedures that we've discussed. If there's any questions, now's the time to do it.
Great presentation, Bruce. What I'm going to do right now is I'm going to unmute everybody. If you have a question, then you'll be able to present that question.
No, $1,549 for the.
Okay, everybody's unmuted now.
It looks like, Bruce, we have a question. Does the person performing the fit test for the N95 need to be certified?
So we were founded in 1985, so we have 35 years.
There is no certification required for anybody to be fit, to anybody to fit test. They need to actually be trained. There is a procedure on fit testing. It's pretty rigorous. So they need to have that training, and they also have to have the right equipment. And if they have the right equipment, and pretty much anybody who has some sort of basic knowledge in that can do it. But it's not so easy. It's a multi-step process, and there's two types of fit testing too. There's quantitative, which is what you use on the N95, and there's quantitative, which is a machine that can actually measure the leakage.
Great. Okay. We have another question. Can an employer be found liable if someone comes down with COVID-19 and caught it at work?
Well, this is, of course, the caveat I have to say is I am not an attorney, but there's lots written about this, and the employer has an obligation to make sure that they're doing everything they can do to protect people from getting exposed to this virus. And I outlined a number of things that really need to be done with regards to putting together a program and all the steps and be prescriptive. Also classifying types of work. So if the employer is doing the right thing and they're being procedural and process oriented in this, have the documentation, then it's a very defensible position to be in if someone accuses the employer of being negligent in causing someone to be exposed. Be process oriented, and I think like any other type of exposure you might have in the workplace, that will be the best way to defend yourself.
There was a question that somebody had asked about the mask, because everybody's wearing the blue mask. You said something that the blue mask does not protect from particles?
Yeah, the blue mask, if it's just a mask, like a surgical mask, or even something that's made from home, this is not going to protect you from particles or the virus itself. I mean, it's really more of a barrier. When you start getting into, and it's a barrier that you put on your mask, or put on your face, I should say, to protect others from you. And also it protects you from touching your face. It reduces the exposure in that case for other people, reduces the amount of aerosols in the air, but it's not going to protect you as a particle. And the same thing with the N95. I mean, people, as I said earlier, are wearing these without any, not being fit tested. They might have a beard and such like this. It's really not going to help you that much from particles in that case also.
Bruce, how often should an employer clean their office? Like deep clean it?
Well, that's a great question. If you ask the cleaning companies, they say every day, but it really has more to do, I think, with those people that are either suspected or have shown from testing that they've been exposed, or they're positive for COVID-19, and that often is a opportunity to segregate those areas, close the office if you have a small office and things like this, and do a deep cleaning. So I think doing deep cleanings as just a matter of course is probably not necessary unless there's some sort of relationship to people being tested positive.
Great.
I got a question for Bruce.
Yes, Michael.
So going on back to Ed's question about liability, and if all the employers are doing everything, they've got good processes and procedures in place, and still somebody does test positive and then a coworker comes down with it, and the employer did everything they could, is they, outside of the negligence, which they proved they weren't negligent, is the workers' comp come into play in any of this in any sense? Will that person be entitled to workers' comp?
Well, the strategy that I talked about earlier is if you have a low or medium classified job from a risk standpoint, then you would not put this person who was got COVID-19, tested positive for COVID-19, on your, what they call your OSHA log as a workplace illness, okay? No different than, you know, if people get the flu. I mean, how many times have you walked into an office where someone comes in, you get the flu, and then 5 people end up getting the flu? That historically has not been a workplace injury or illness, and that wouldn't trigger workers' comp. And I think at this point, that's a great policy and procedure to do, that you can't really have a cause and effect. So.
Great, thanks.
Well, thank you, everybody. Unless there's any other questions, I'm sorry.
I just want to thank you, Bruce, for chairing our task force. So just so everyone knows, Senator Bucco with the New Jersey Legislative District 25 has put together a task force, and we're partnering with him at the chamber. And Bruce has agreed to chair that committee. So we're grateful for your time and your expertise. So thank you, Bruce, for all you're doing for the chamber and for the community.
Thank you very much.
Well, this was, I mean, I learned a lot from you. Great presentation, Bruce. And if there's any other questions, we have a few minutes left. You can ask at this time or put it on the chat.
Or you can email me a question, or I can follow up if you have any other specific things that you want to discuss. So.
Hi, hey Bruce, I have a quick question. As we look back to the dose slide and thinking about the risk levels for the dose side of this particular I guess, issue we have, dose relative to age and age group. In other words, I guess the care facilities that are struggling, that maybe be over 65 years old, that dose level changes similar to maybe retail and facing the public at a different dose level and a risk level as well. Maybe talk about a little bit of how age affects that.
No, that's actually a very good point. When you start looking at dose, you also have to look at the receptor. Who's the person you're dealing with? And when you have something like an infectious disease, or if you have people with drug therapy, not necessarily recreational drugs, or you have people exposed to chemicals like this, if they're compromised in any way, they're going to have more deleterious effects than someone who is effectively a healthy person, okay? So the immunocompromised people, which you people have heard a lot about, they have to be segregated out of the population in a lot of cases, because it doesn't take as much of an exposure to this virus to have a bad effect on someone who's immunocompromised, which includes the at-risk people who are over 65 or over 70, depending on what age you want to call elderly anymore. So
We're all young.
yeah, that's part of the balance right there. Again, from a workplace standpoint, when I talked about the worker cohort, that kind of takes away a lot of the people that are seriously ill or the extremely young or the extremely old. Doesn't necessarily eliminate that, but it does reduce that population. And so what's going to happen is people in the workplace and people personally are going to have to identify, are they at a higher risk than they would be than other people? And they're going to have to take more precautions. There's no question about that.
Thanks for that.
Okay. Thank you very much. I appreciate the time you've taken, and everybody be healthy out there and get back to work.
Well, thank you, Bruce, for your presentation. Your presentation was fabulous. I also want to let the other people that are still logged on, we're doing these seminars every day at noon. In May, we're going to switch them to 11 a.m. So stay connected with the chamber. Anything the chamber can do for you, please let us know. We're here to better serve you. And Bruce, thank you so much for this information and the